So, what in the world is oral facial myology? I love that title. And what does it really have to do with picky eating? Well, the way we're going to find out is we're going to talk to the fabulous Mary Billings. And if you don't know Mary, well, I know Mary. First of all, she's incredibly busy and incredibly bright. And I'll just tell you two things about her. She is the director of the Oral Motor Institute, and she'll probably tell you a little bit more about that as we chat. She's also the past president of the International Association of Oral Facial Myology, the IAOM. And she's an instructor. She teaches all over the world. And she also has a private practice with a number of fabulous employees who I just taught a course for. So I'm really pleased to introduce you to my friend, Mary. And she also tells really good jokes. Mary, you're so good to do this with us tonight. I know you went back to your office just to join us this evening so we could be here on the Throatscope page. And I would love for you to just jump right in, Mary, and tell everybody what in the heck is oral facial myology?
Well, thank you for inviting me, Melanie. It's always a pleasure to spend time with you. I do want to clarify, I am one of many directors with the Oral Motor Institute.
Yes.
And it was quite a compliment to follow in the shoes of our founders, Pam Marshala, and our dear friend, Diane Barr, who first started the Oral Motor Institute. And our mission and our goal is to bring more information surrounding our specialty and what it is we do. So oral facial myology is a term that the people who started the International Association of Oral Facial Myology 50 years ago came up with. And predominantly what it is it's the study of the posture of the tongue, the lips, the jaw, and its associated movements. But oral facial myology was just a field of study, but it's also and always has been a scope of practice for speech language pathologists. And what it should most likely is, well, that's our profession, our study, what we treat are oral facial myofunctional disorders. So whenever I'm writing or I'm communicating with people, I'm talking about the disorders themselves, and they are many. And so for many, many, many years, what I know in terms of oral facial myology, because I've read all the books that go back 50 years. I'm kind of a first edition addict, and I go through rare bookstores to try to find books of mine, of my passion. And one of the things that we find is that for many, many years, that we've only talked about tongue, resting posture, tongue, lips, and cheek, resting posture. And I don't want to indicate that that isn't important, because it most certainly is, but it's only part of the pattern, because that tongue resting posture is involved with the serious complexities of the system from which it sits, all right? And so we look at the systems of suck, swallow, breathe, and how that suck, swallow, breathe affects healthy breathing. Craniofacial and dental facial growth patterns play a clear role in the emergence of oral facial myofunctional disorders. And a big part of that is chewing. So now you begin to see how feeding sort of comes through. When we look at that chew, we're looking at the quality of the bolus that we're producing, because the quality of the bolus has a lot to do with how the gastrointestinal system breaks it down. And in most cases, with oral myofunctional disorders, we're going to see a lot of people chewing inappropriately and taking in a lot of air.
Because digestion starts with the chew.
Digestion, that is exactly right. I have a good friend who's a physical therapist, and she came into specialing and working a lot with myofunctional disorders. But one of the things she shared with me I found so curious in my many plus years of working, I'd never heard this. She said that 70% of her referral base as a physical therapist were from gastroenterologists. And when I asked her that, I said, why? And she said, for gastroesophageal reflux. And she was adamant that people who suffer from a reflux disorder have an airway problem. Now, we certainly see that in our babies today, don't we? Yes. And our toddlers. And perhaps maybe some of our picky eaters who we clearly see will have irritable bowel, right? a lot of different issues.
Well, when you were mentioning that there's so much more to this than just tongue thrust, that's what you were really saying there. Because
Yes.
everyone's like, oh, you do tongue thrust therapy. Well, yeah, that's a small piece of it. But for me, and I'm not a certified orofacial myologist, I've taken the 4-day introductory course twice because I love it. And it's really helped me in my pediatric feeding career. But for me, what orofacial myology is really about balance and facial structure and how that influences the way we perform, the way we chew, the way we digest, the way we swallow. That's function. That's known as function. And what that comes down to, as you just said, is physiology as well as the motor component. But can you just speak a little bit more about facial structure? Like, what does that really mean? Because I think, we think of structure like the structure of a house and the foundation and the walls and the
And
roof.
that's actually the exact same analogy I use when I teach my 4-day. I talk a lot about face and facial growth. People can go out and there are books galore today where they really talk about and the focus in the area of oral mouthfunctional disorders for many years came from the dental world. That's what tongue thrust. Tongue thrust was a term. Reverse swallow is another one. It was coined by dentists. So that tongue thrust pattern was identified by ASHA through speech language pathology. And when I went to school, it meant they had an S and a Z distortion, and that tongue is just in the wrong place. It's so much more than that. So the analogy that I use when I'm teaching about the face and craniofacial is when we build a house, the very first thing that we do is we dig out the dirt to lay the foundation. Mm-hmm. Now, I don't know whether you have basements in Colorado, but I live in Tornado Alley, so every house has a basement, we've learned. And part of that is establishing the I-beam that goes from one side to another, and that provides core stability. Once we have that central structural support, we can put on the floor, and then we can put up the 2x4 as we start to put up walls, and we can construct a roof on that. And once all of that's in there, well, then our systems come in. Our utilities can start functioning with plumbing and electricity and heating and cooling and all of that. And so eventually what happens is that we know if something destabilizes that solid foundation, that first built structure, then the rest of the structure is going to start to suffer. It's going to start to shift. So we get foundations that crack. We get cracks in the walls. We get doors that aren't level anymore. We get shifting in the roof so the animals can go up into the attic. There's a lot of different things. And if we think about our face and our head, it's no different. It is the structure, in all honesty, upon which we build our health, because there are two functional systems that must survive in the human body. One is the ability to breathe, and one is the ability to swallow. We start doing that neonatally, and we don't stop until the moment we die. We're still handling our secretions. We're still swallowing. We're still breathing. So we need to build that good foundation. If we start having functional changes where the function can't operate within the home, then we're going to start to see the changes in the structure, like narrowed nasal system, deviated septums. We're going to see changes in our hormonal system, because depending on how the cranial bones are shifting, we're going to have changes with pressure in our pituitary gland, as well as our thyroid. Our thyroid sits right there next to the hyoidal complex system. What is that designed for? Swallow. So this whole notion of that tongue rest posture was not wrong, Melanie. It was not wrong, because bone needs pressure to grow, and that tongue provides that first stability. For many, many, many years, and I know you've heard it, we have wonderful colleagues. I think probably the first person I heard this from was Jennifer Meyer out of Texas when I took her class, because we all seem to take each other's classes, that fine motor skills will never exceed gross motor. Have you ever heard it?
She's one of my best friends, and I've taken her courses. And
right?
As a matter of fact, I interviewed her for a Facebook Live as well.
Yeah, she's lovely. I enjoy every minute of it. And I know that we hear that from our colleagues all the time. But what I'm going to leave you with, and how I'm going to end this, is I think we have it backwards. So we want to say that we need to have the stability of the trunk and core strength and all of this movement so that we have hip flexion, and then we can get up on the feet. Feet goes and builds in within the feet. But the reality is the very first muscle that functions neonatally and develops, a baby is not born holding up their head. A baby is not born trying to roll over or having shoulder girdle or abdominal strength to roll. A baby has tongue. So the tongue becomes the first primary postural support system. And when that tongue is not moving adequately up and down, then the ability for the rest of the system to stabilize begins to shift and is sometimes compromised. And I don't think as speech pathologists, we're very well educated in looking at the anatomy and the physiology to really figure out that correlation.
That's such a good point. I'm using my throat scope here because I just want to demonstrate your concept, and that I think what people think about in terms of speech pathology, but also oral facial myology, is this right here.
Oh, yeah.
Right?
Oh, yeah.
But really, in order for your mouth to work well and to operate efficiently and effectively, it's got to have a good nose and a good airway, and all of that is connected, as you just said,
and
right?
System, the breadth and the width of our face, right?
So important. Yeah, exactly.
And the roof of our mouth.
All of this, right?
What's the tongue going to pump up against if we don't have a solid core palate?
Yeah.
Right? That's another thing that we build our support from. So you're absolutely right. Mm-hmm.
For the parents listening, I'm going to try to show you my palette. It's a little tricky with me doing it myself, but so that's what Mary's saying is you've got to have, the tongue needs that stability to push up into the palate. And that's actually what helps shape our face as well.
Grows your face. That is correct.
Yeah. Yeah. All right, Mary. So what do you think this has to do with picky eating? Especially let's talk toddlers and then a little bit older. And then we can take even older kids from there once their face is formed.
So when we talk about these functional systems, right? And I'll go back to this whole idea of the primary function of the entire oral facial complex is to breathe, which gives us life, and swallow, which gives us nutrition. Mm-hmm. Then suck, swallow, breathe becomes to urges very, very early in life, right? And neonatally, we know that it is present and developing by 12 weeks gestation. I tell parents this all the time, that the studies will show how much intake a developing infant is capable of. That being said and done, it does not completely, the swallow and the swallow physiological process does not completely mature until that 40th week of pregnancy, gestation. So we think, I have a niece who's a NICU nurse. And I think I had one that was 35 weeks. And I think about all the feeding problems that he had that I just could not figure out. So a lot of times when we look at these babies, they haven't finished developing, and they can be experiencing all kinds of things. A lot of times we're going to see these are their babies with our high bubble palates or very narrow palates. They can be some of our babies. I know I've seen a proclivity in the last few years that every time there's a baby who has a feeding problem, we want to attribute it to a tongue or a lip tie, period. Yeah. And I'm like, are we looking at everything else? Because the cranial structure, obviously plagiocephaly can play a role in that suck, swallow, breathe, as can torticollis. If I'm working with a 90-year-old and I have to teach them how to keep their head this way in order to swallow, it all goes back to the swallow for me, because we're sucking and we're swallowing and we're moving through different food products before we get to the next series, which is the motor of chewing, which takes us to the picky eating. And one of the biggest things that struck me is our good friend Diane Barr speaks greatly about working the jaw. Whenever she's talking about little ones that are not developing chew, she will talk about strengthening those jaw muscles.
As a matter of fact, Mary, I'm so glad you brought that up because Diane is going to be our guest on another Throat Scope Facebook Live in, I believe, August. So I'll put it in the comments for everybody, and she's going to be talking specifically about that point. So yeah, keep going though. I'm sorry to interrupt you.
Oh, no. I'd stop anywhere for Diane. She's an amazing leader. And I've learned a great deal from her. And she says she learned a great deal when she took my class, and I enjoyed having her. It's a little intimidating, I think. I enjoyed every minute of it. But if we look at all these factors that people continue to look, often what we find is that people are going to say, well, oh, he has low tone. How many times have you heard that?
Yeah.
Just a low tone kid. And we can see this for chewing. The masseters are the strongest muscle in the human body. Number 2 is tied with the quads and the glutes. If you look at by its size and focus, why would the masseters be the strongest muscle? Because they work in conjunction with our jaw, which is always moving for speech and for swallow and for chewing.
But also, doesn't it also, and I don't know if I'm right here, doesn't it play a big role in stability overall for the face as well?
Absolutely. So in older kids, I just had this conversation with a couple of my staff members who've been doing some myofunctional therapy, and they have these kids they can do every exercise that they give them, but the kid's mouth is wide open like this. No matter what they do, the jaw falls open. So once again, I'm redirecting them back to work on the masseters so that they can remember that the muscle stretches out over time. Mm-hmm. The fibers and the tension of the fibers change. And so when you're used to having your jaw hang open, it isn't enough to just say, hey, close your mouth.
That is such a good point.
It isn't enough. A good point. You have to work to kind of rebuild that muscle, bring it together, and most importantly, bring that proprioception together.
Yes. Yeah. And just for all the parents listening, the sense of proprioception, it's one of our senses, and it really has more to do with anything with how your muscles and your nerves and your joints kind of all talk together. So if you're getting feedback like this,
right,
most of the time, that's the signal your brain is getting. And when we suddenly start asking a child to close their mouth and perk up their eyes, all of these muscles are connected, then it's only going to be temporary. It's like telling somebody who's used to sitting like this to just sit up straight for the rest of their life. It takes a long time to retrain not only the muscles, but also get that feedback from a proprioceptive standpoint saying, oh yeah, I'm in the right place. Knowing when you're in that right place, that right space.
You know, Melanie, what I've come to really respect, I have so much respect for my feeding specialist colleagues. It's very, very complex. And if I can send one message to the people who, tune in with you and want to learn from you, as I still continue to do, it's that you have to understand that there's a lot that goes into properly recognizing and diagnosing a feeding disorder, as well as developing that treatment goal. Because I'm here to tell you, when we do it incorrectly, what happens, if we can start it early enough, we can actually show effective results with our kids. But if we do it wrong, we get over anxious and we start forcing kids whose systems are not ready for it to do it anyway, it backfires, and then they truly become the picky and selective eaters that you often deal with, and picky and selective adults. There's an entire population of adults who still struggle. They want to do better, but they can't. And part of the reason is because we may be forcing them, their neurological and their physiological systems, to do something that it's not capable of doing yet. And so what do? They reject one of the second most fundamental function of the body. Eating.
Yeah. Yeah. When I talk to parents about that, I always equate it to a young gymnast. So I always say, it's like if your daughter loved gymnastics and she's been going every day for a year after school, she is loving it, but she gets a brand new gymnastics coach. I kind of consider myself my kid's feeding coach. She gets a brand new one who hasn't laid the foundational work that she needs to do that flip on the balance beam and land square on that balance beam one more time. And if you don't have that foundational work, it doesn't matter how many times that coach says, do it again, do another flip, or eat another bite, right? You don't have the foundation for the stability and the strength that you need to make that motor movement and then develop the coordination because you have that foundational skill. You know what ends up happening? You quit gymnastics.
Absolutely. And
same thing with our kids.
We can use that same analogy in speech therapy for all of those kids that can't make R.
Yeah.
I routinely tell people all the time, kiddo, this is not your fault. You've been doing therapy with somebody somewhere else for years and years. Honey, I know you can hear the sound. You just don't know how to make it. You don't have the tools to move your tongue to the right placement. And when I can give them that, then all of a sudden we begin to see changes.
Mm-hmm.
So, you know, I have to admit to you, Melanie, that I came into, and I'm considered a feeding therapist. I consider myself.
Oh, you're a great feeding therapist.
I started by working with feeding in adult care. I did geriatric care for a good 10 years.
Oh.
But after I moved into orofacial myology, I had so many children that were coming to see me where the parents would say, this is great. Now what can you do about that picky eating? And I realized when you asked me, what's this whole cranial facial thing have to do with it? I had a picky eater. My younger son was he was born with bilateral ear infections and was a walking myofunctional case for years and years. His failed interventions by the time he was 14 or 15 is what drove me to continue my education in here, because I didn't want other parents to have to go through what I went through with mine. But he was a selective eater. You know, he had his regulars. Today, as an adult, he doesn't really have that problem. He was able to work through it. But one of the issues he had was a class 2 D2 bite. So if we look at our dentition and our jaw sits too close together, that's what happens with a class 2 D2 is that TM joint, it rotates and the teeth come in really, really tight. Chewing was difficult for him. He didn't have the movement to get that rotation and that rotary action, right?
Right.
And so once we were able to move him out of that deep bite, then he had more room for mobility. And then slowly he got over his psychological, social, emotional issues with food and started trying new things. So I'm
assuming though didn't just happen overnight, because all of those learned behaviors based on the emotions around food and the anxiety around it, et cetera, you know, as you said earlier, becoming a picky eater is very complex and no two kids are alike ever. Yeah. So whether, as you said, it starts with something structural like the TMJ that you were talking about right here.
Right.
The whole point is just because we go get that fixed doesn't mean the kid suddenly becomes an adventurous eater. There's still a lot of work to do. And I know you worked with him quite a bit. So Mary, on our final note then, before we start taking questions from our audience, is can you tell me, and I know that this is just a broad number, but if you had to come up with a number in your years of doing this, how often do you think you see kids who come in with speech issues? And let me ask you twofold. How often do you see kids come in with speech issues that also have the need for more oral facial myology type of treatment?
Oh, it's
just tell me about speech versus OFM, and then I'm going to ask you about feeding.
Okay, so I didn't always do it this way, because for the longest time period, it was sort of like, this is a myofunctional problem, and it's reserved for this age bracket. The more I began to delve into the anatomical and physiological aspects, I began to track it back. So when I do assessments on kids from all the way up now, we always do a very intensive, I've coined a new phrase, I call it an oral structural functional exam. Structural
structural functional exams.
instead of oral mechanism, right? The mechanism, structural functional. So we can look
Functional.
at the size of it.
Yes.
And I would say probably 80% of our kids who come in are having these underlying, remember, an oral myofunctional disorder is not a tongue thrust. It's not where the tongue is sitting. It's a series of symptoms that deal with the systems of lip closure and jaw movement and cheek and bolus collection, okay? And we're looking at all of those systems. And so we tend to see a very large part of the population. I have a colleague, Patty Fisher. She's been working even a lot longer than I have. And I had the great opportunity to teach a one-day class following my 4-day in Brisbane with Patty last year. Hello to all my friends in Australia.
They're all here.
One of the things that Patty really worked to reiterate in the class is the primary function of this complex is breathing, swallowing, and speech and music and all the other things we do with our mouth is a secondary function. And as professionals, we've always been trained that it's the enunciation and the language that predominates everything. But if we can back it down and ensure that the two functional systems are in place, then we're going to be able to work through, no matter whether the child has a cleft or ASD or anything else, we're going to be able to work through those issues with them to ensure that they can have better speech production. If everything's working, speech comes out.
That's like a tweetable moment right there. If everything's working, speech comes out. I like that. I'm going to tweet that.
Okay.
Well, last question for you is, so in your career, clearly you see the need for more myofunctional therapy to coincide with speech and possibly even language development. What about feeding? How often do you see kids who come to you strictly with the concern about feeding? Okay. That you actually feel that at least a big piece of the puzzle is the foundational myofunctional piece.
You know what? That's a perspective switch for me, because it seems like my caseload, and ever since COVID hit, I have more babies, and it's very nice. In a time like this, there's nothing better than hugging onto a baby, right? And most of them I'm seeing for feeding therapy, because they have not yet developed and moved through those milestones up to the age of 2.
I see.
But if you're asking me a 3, a 4, a 5, a 6-year-old, there are certainly plenty of those kids who come just for the feeding therapy. And to a fault, they all have managed to adapt in some way or compensated in some way that it is manifesting itself again in this feeding issue for them, whether they have interrupted suck, swallow, breathe, breathe, swallow, the collection process. I will often tell my parents, if you, every time you go to the stove and you're going to cook, you burn your hand on the burner. The next night when you come home, are you going to want to turn the stove on?
No.
You're going to you might be willing to turn the oven on and try and throw something in there, or you might try a microwave or even maybe an electric skillet, but you're not going to want to turn that stove on. And I think a lot of aversive eating in children is because it doesn't taste good to have food that's stuck all over inside your mouth. And whenever I have a parent who doesn't understand that, I will challenge them to go out to dinner that night and hold that piece of steak in their cheek for a good 30 seconds and tell me if they get all the way through eating their steak. And usually the answer is no.
That is such a great point. I especially just want to close here before we start taking questions on the fact that a child's face is continuing to change from birth to gosh, even the teen years, really, right? But
In
especially
boys,
that birth to what, Mary, age 7, 8, is that kind of,
dominantly, right,
yeah,
right. So that's in terms of facial. The
yeah,
cranium is full grown by 2. So the facial bone expansion is usually 7,
mm-hmm,
8. And then again, we're going to see more breadth, but it's much, much smaller. There might be a surge in growth patterns for boys in particular. I saw that with my oldest son at
yeah.
a later age, but usually for females, it's pretty much ready by the time they're 9 or 10.
Well, for me, what I find interesting about that is that we will get these kids who'll go through a typical stage of picky eating from about 18 months to maybe 3 years, kind of expecting them to grow out of it. But yet they end up on our caseload when they're 4 or 5 because they never did grow out of it. Well, if we really look back at their history, and it could be that I'm just now trained to really look for this, but when you look back at their history, I'm not saying this is the only reason, but it's a piece of the puzzle. There's often some sort of myofunctional difficulty that I can pay attention to, and it may not have been a big issue when they were 2, but as their face started to change and their jaw started to grow, maybe now that tight frenulum is really tight. Does that make sense?
Mm-hmm.
Yeah, maybe the kid he was breastfeeding and bottle feeding just fine. He did not great with solid foods. We did okay. So he's probably just going to grow out of picky eating. And there are many different factors, as we keep saying, that come into pediatric feeding disorders. But we have to remember that your face changes over time. Things start to shift. And if we don't have a good, balanced facial structure, everything starts to torque.
Everything. I love that word. Everything starts to torque. It starts to move. Just the day before yesterday, we had a beautiful little girl who came in to see us. Mom was concerned. She wanted an airway assessment, which I found just absolutely wonderful, that a parent could say, I think my child has an airway problem, because we used to reserve that just for professionals. And sure enough, she had giant tonsils. She was not breathing. Her speech was not quite so bad, but guess what she was demonstrating? At the very end of the report, Mom said, yeah, she really doesn't eat very much. She's really selective. So I'm going to challenge you. If anyone in this group who's signed in tonight has had a really massive head cold, do you feel like eating?
Yeah.
Does anything taste good? Well, you have this wide open mouth because you cannot breathe, which is also simultaneously changing the structure of your face. And nothing tastes good. Is it any wonder that we tend to avoid it? Of course not. So kids are not consciously manipulative enough to make that decision at 2 and 3. They don't have the maturity and the understanding to do it. They just know what they don't like, so they tend to avoid it.